This last video in the immunology and joint disorders section will be about gout. Gout, again, is not an autoimmune condition, but it does involve inflammation in the joint space and therefore is relevant to discuss with the other disease states we've been talking about. Gout is an inflammatory disease state that's caused by a response to hyperuricemia. Hyperuricemia is defined as elevated uric acid in body fluids. Again, gout is not an autoimmune condition, but it is an inflammatory disease state. When it comes to underlying causes of arthritis, gout is the second leading cause after osteoarthritis. It affects over 2 million people in the United States, and its incidence increases with age. Unlike some of the other arthritis conditions we've talked about, gout is significantly more common in men, with a 9-to-1 ratio compared to women. The etiology of gout can be attributed to a single change that occurs in fluids throughout the body. That specific factor is called hyperuricemia, which is defined as elevated uric acid. Hyperuricemia is essential for the development of gout. This means that you cannot have gout without hyperuricemia. However, it is not the only factor that leads to the development of gout, because only about 5% of cases of hyperuricemia go on to develop gouty arthritis. And therefore, there are some other environmental and external factors that contribute to the development of gout in individuals with hyperuricemia. Those factors include things like older age, and specifically age over 30 years. There can be a genetic predisposition to developing gout. Some individuals have a mutation in one of the enzymes that metabolizes uric acid, and this can lead to a greater propensity to develop gout. Excessive alcohol or consumption of foods that are high in purines, like red wines, meats, and cheeses, can predispose to the development of gout. Obesity is another risk factor, as well as certain drugs, and specifically thiazide diuretics. To summarize, hyperuricemia is required for the development of gout, but not all hyperuricemia turns into gouty arthritis. There must be hyperuricemia plus another one of the risk factors or underlying causes in order for a condition of gout to develop. In order to understand hyperuricemia, we first need to review the normal biochemistry of uric acid. Uric acid is the normal metabolite of purine nucleotides like adenosine and guanosine. Adenosine and guanosine are converted through a series of enzymatic steps to uric acid. One of the enzymes that is very closely involved in the metabolism of purines is xanthine oxidase. This is important to note because xanthine oxidase is one of the targets for some gout treatments. Uric acid is excreted in humans by the urinary route. As long as uric acid levels do not get too high, this process typically is not problematic. However, uric acid at normal body pHs can be ionized to urate ion, and this charged molecule can then form salts with sodium. One such salt is monosodium urate, or MSU. Therefore, it is important that uric acid levels are maintained within a normal range. Hyperuricemia occurs when uric acid levels go above normal limits. This value is different for men and women because men tend to have higher uric acid levels in general. Hyperuricemia is evident in men when the uric acid level is above 7 milligrams per deciliter, and in women when the uric acid level is above 6 milligrams per deciliter. There are a few things that can result in the development of hyperuricemia. You can either have overproduction of uric acid or under excretion of uric acid. Said another way, you can get too much uric acid because too much is made, or you can have too much because it is not removed fast enough from the body. Some factors that lead to overproduction of uric acid are increased metabolism of nucleotides, like adenosine and guanosine, due to increased cellular breakdown, for example, or increased intake of dietary purines, which are high in foods like meats, cheeses, and red wine. You can have reduced excretion of uric acid due to kidney damage. Interestingly, humans are the only mammal that suffer from this problematic balance of uric acid. In other mammals, there exists another enzyme called urase that metabolizes uric acid to allantoin, which is much less reactive and does not form crystals with cations. Therefore, most mammals do not suffer from this problem of uric acid elevation causing the formation of sodium salts. Once hyperuricemia is present, gout can possibly develop. Again, gout develops in only about 5% of individuals with hyperuricemia. Once hyperuricemia occurs, there is a series of steps that lead to the eventual presentation of gout as we know it. The first is that at normal body pH, urate is ionized to urate ion and forms salts with sodium like monosodium urate. These monosodium urate crystals deposit in connective tissues, especially the soft tissue of the joints. This deposition of a crystalline structure within the joint space causes an inflammatory activation. Initially, neutrophils are activated, and these neutrophils migrate to the joint in an attempt to phagocytose or destroy the MSU crystals. However, this process can cause the neutrophils to rupture, which leads to the additional release of cytokines, enzymes, and free radicals. This becomes a feed-forward cycle of inflammation that leads to pain, joint swelling, and other issues. In addition, repeated episodes of gout can damage articular cartilage permanently. In terms of clinical presentation, all cases of gout will have one underlying factor in common, which is that they will present with hyperuricemia. Blood levels of uric acid will be elevated above 7 in men and above 6 in women. The other primary clinical presentation of gout is acute gouty arthritis. This is defined as a sudden onset of pain and swelling in a single joint. And among patients with this presentation, over 50% exhibit sudden onset in the metatarsophalangeal joint, which is the base of the big toe, as shown in this image. The joint will typically be warm to the touch, very red, tender, and swollen. And there will also be signs of systemic inflammation, like elevated ESR and CRP. There are other presentations of gout, one of which is called Topacious Gout. This is when the MSU crystals deposit in soft tissues like the ear or the Achilles tendon, and this typically signifies a more chronic stage of the disease, as opposed to the acute gouty arthritis I described previously. Another clinical presentation of gout can be renal stones, which is when MSU crystals deposit in the ducts of the kidneys and can cause some kind of kidney stone. Patient assessment in gout includes both a physical exam of the infected joint, as well as some blood chemistry and arthrocentesis of the affected joint. Blood chemistry should reveal an increase in white blood cells or leukocytosis. Also, serum uric acid will be elevated, and 24-hour urine collection uric acid may also be elevated, as described previously. That would be above 7 milligrams per deciliter for men and above 6 milligrams per deciliter for women. Blood chemistry may also reveal an elevated ESR. Arthrocentesis will reveal the presence of white blood cells as well as the presence of monosodium urate crystals in the aspirated joint fluid. An example of what the MSU crystals look like under a microscope is shown here. Finally, chronic gouty arthritis or topacious gout may require an X-ray to diagnose the cause of chronic disease. Unfortunately, acute gouty arthritis can become degenerative if it happens repeatedly. Similar to rheumatoid arthritis, this can damage articular cartilage permanently and make that damage irreversible. Another common complication of gout is kidney stones. These can also happen very frequently and be problematic to consistently remove. Usually, once individuals attain control of uric acid levels, they have a much better prognosis. Some of the other monitoring parameters, including monitoring the length and interval of attacks of acute arthritis. And unfortunately, a younger age at onset predicts a more severe prognosis of the disease. I'm returning to this table to illustrate again how osteoarthritis, rheumatoid arthritis, and gout are similar and how they are different from one another. Take a moment to review the first two lines of this table that compare OA to RA and gout in terms of historical features, features present on the physical exam, as well as laboratory features.